this is we are recording this case also. So now we are, this was the case of dysphagia, elderly lady, and we have reached to the provisional diagnosis, that is the carcinoma stomach. And now I'm going to ask Dr. Saima how to proceed further. So ma'am, so what investigations you would like to do now?
Okay. First of all, I would like to do investigation for the diagnosis of my for the diagnostic investigations of carcinoma of the esophagus. For that, I will go for upper GI endoscopy with biopsy.
Mm-hmm. So you want to do an upper GIT endoscopy and biopsy. Very true.
Yes, sir.
So you're going to use which endoscope?
Sir, GI endoscope, gastrointestinal endoscope.
Say, fiber optic or rigid?
Sir, fiber optic.
Fiber optic. Very true. And what do you want to see in that?
I would like to see the whole of the esophagus, like starting from the upper part, like pharynx, esophagus, and tell if the type of the mass, its location, overlying mucosa, any ulceration. I can even examine if the mass allowed me to go into the stomach, as I'm suspecting esophageal mass. So then I'll see the mucosa of the stomach as well.
So why you have preferred endoscopy in addition to this thing? You could have done barium meat first, then gone for endoscopy. So why you did not go for barium meat first, barium swallow first?
Sir, okay, sir. There are okay. I go for endoscopy first because this will give me the direct view of the overlying mucosa, type of the gross structure of the mass as well, macroscopic structure of the mass, its location, and along with that, I will be able to have biopsy at the same time, tissue for biopsy as well at the same time. Moreover, if I used barium initially, I would wait for it for so that it is like excreted from the body before going for endoscopy. Otherwise, I won't be able to see the mucosa properly.
Very true.
Because it will be colored by that.
That is right. Now I'm talking is exploring your thought process.
Yes, sir.
Can there be an indication of barium after endoscopy?
Yes, sir. If I'm not able to pass the endoscope in through the mass, then I won't be able to see the distal limit of the mass as well. So for that, I'll have to go for barium because it's liquid and it can pass through through the smaller channel as compared to that one. Moreover, if it is proximal stomach mass, which I will miss on the I couldn't find any mass on the endoscopy, and I'm suspecting it is proximal stomach. So in that case, I will also go for barium is also good in that state as well, like superior to endoscopy in that case, in order to locate that mass.
I think this is a good argumentation which you have given. Okay. What will be the on barium swallow? What findings do you see which give you an indication this could be cancer?
Sir, shouldering of the esophagus will be there. Distal esophagus will be there. Irregularity of the overlying mucosa and narrowing of the esophageal channel.
So, is there a name given to that also, which resembles some fruit or something?
Sir, apple core.
Apple core. But these are not important questions. Just I'm continuing them also. So you have done the upper GIT endoscopy with biopsy, and it turns out to be it's a carcinoma of the esophagus.
Okay,
sir.
G, please.
Sir, barium is done first to rule out the diverticulums so that the endoscopist will be careful while doing the endoscopy because the theoretical risk of perforation. Is it not so, sir?
Well, the incidence of diverticular, which you are talking about, is so low that one can do endoscopy without barium studies also. But having said
Right,
so,
sir.
if you say that you want to do barium first, then that will be your main reason to justify doing barium swallow first.
Sir.
That is, so that is on this issue. So डॉक्टर साहब अब क्या इन्वेस्टिगेशन कराना चाहेंगे आप? कंफर्म हो गया?
Confirm ho gaya. Now I will do investigation for staging of the tumor. Staging of that this will include chest CT scan of the chest, abdomen, and pelvis after doing my BLIs, baseline investigations also.
So you're talking about is the general concept of the three types of investigations.
Ji
Universally,
sir.
one is to
Ji sir.
diagnose, and one is to general fitness, and if the
Ji
diagnosis
sir.
is cancer, then the spread.
In the spread. Yes sir.
Possibly, the thing which is important to remember in carcinoma esophagus is that fitness is very important,
Ji sir.
because this is one of the few cases in which chest has to be opened, and one has to go through chest, or open chest, and that has increased morbidity. Cardiovascular fitness is very important. Lung function is very important in this case.
Ji sir.
So therefore, before even going for spread of the tumor, staging,
Okay,
it
sir.
might be a good idea to find out whether patient is fit or not.
Okay, sir.
In this
Theek.
case, it is okay. You are doing this thing because clinically you think that the patient is fit, and your argument is, okay, really sure she can do, she doesn't become breathlessness in walking, she doesn't feel excessively weak, she doesn't feel weak. That is okay. She's not a smoker, and she doesn't have a past history of respiratory disease. She doesn't have a cardiac disease. So therefore, your argument should go, even in this line, is also correct. But
Okay, sir.
other cases, if someone is very weak in front of you, then
Ji sir.
it will be important thing to find out fitness first, because
Okay,
if the patient is not fit, the patient is inoperable.
Ji sir.
So if a patient is inoperable, why you want to stage? Thought process.
Ji sir.
Although or it might
Bilkul sir.
but that's the thought process. Because
Yes.
majority of the patients, a significant majority of the patients of carcinoma esophagus, they are inoperable. That's the issue.
Ji sir. Okay.
So therefore, to see fitness, which tests you would like to do?
To see fitness of the patient, I would like to do just baseline investigations, which include full blood count, including hemoglobin levels, liver function test, all the baseline serum electrolytes, serum sugar levels, along with that chest X-ray, ECG, electrocardiography, and echo of the patient, because she is more than 50 years of age. And along with that, I'll go for a pulmonary function test, because she had history of pulmonary tuberculosis. So I would like to include that as well.
It's a good answer. But in carcinoma esophagus, when we are talking about lung function test and echocardiography, they must.
जी सर.
उसमें जो आपने argument दी कि because she has tuberculosis doing it, that is also there. I'm not arguing that. But even if that is not there, in any patient in which we are planning an operation on esophagus, two tests, lung function test and echocardiography, are the most important tests to assess the fitness.
Okay, sir.
Which is little reverse in other cases, if you think of.
जी सर बिल्कुल. If indicated तो वो करते हैं.
जो आपने ये करना इसमें जरूरी है.
ठीक है.
Okay. So you have done these and they are also fit. Now you want to see the spread of.
जी सर.
Which tests you want to do?
Sir, I want to do CT scan of the chest, abdomen, and pelvis,
Mm-hmm. And this is to see.
and to see the pulmonary mets,
Mhm.
liver, and peritoneal mets if present.
Okay. Anything else?
Okay. I would also like to do PET scan on the basis of the availability
Why you
for
want to do PET scan?
sir, for metastatic disease, especially in the bones.
So what about you're going straight for the PET scan without bone scan?
Um, Sir, I can go for bone scan as well,
Mhm.
depending upon the availability of the investigation.
Do I understand this thing? The PET scan will be present. That's okay because the PET scan is done by the radio by the atomic energy, and that's being done by that. Yeah, I can buy that. Okay.
Okay, sir.
So what you're talking about is metastasis. Uh, well, about PET scan and bone scan. If the patient has a carcinoma, like a proven carcinoma, and then possibly bone scan would be fairly good enough, because if bone scan is showing a hot spot, then it means
Okay.
it is cancer, because there's a very, very predominantly proof present as a cancer. The
Ji,
problem
sir.
is if there is no primary is known, let us say, and you do a bone scan and a hot
Mm,
point comes, and now you're not sure, okay, this hot point, what it is, could it be met? Then PET could be a
Ji, sir.
option. Something like that.
Okay, okay, sir. And sir, and esophageal, in order to know the T of the the spread of the disease, we will have to go for endoscopic ultrasound if available.
Mhm.
Along with that, bronchoscopy, if it is locally advanced and we want to know the its spread to the trachea, we can also go for that
Mhm.
in case of staging. Lower esophagus, no. Even diagnostic staging laparoscopy can also be done.
डॉक्टर साहब ये तो आप ठीक बता रही हैं चीजें हाँ बात आप सही कर रही हैं कि you can do esophageal endoscopy also. Endoscopy can tell you give you some additional information,
जी
especially
सर.
if you are expecting it to be an early carcinoma. मगर आप तो
ओके सर.
एडवांस से चेक कर रही हैं,
जी सर.
और एंडोस्कोपी पे आपको ट्यूमर भी नजर आया है, और जो कि एक नैरोइंग नजर आई है आपको, तो पॉसिबली अल्ट्रासाउंड
लोग.
लोग की कितनी अहमियत रहेगी नहीं इसमें,
ठीक
अल्ट्रासाउंड
है सर.
एंडोस्कोपी की। जहाँ तक आप
ओके सर.
एंडोस्कोपी की बात की, उसमें भी पेशेंट डजंट गिव हिस्ट्री ऑन रेस्पिरेटरी सिम्टम्स और एनीथिंग,
तो
जिस
ना करें.
आपको बहुत जरूरी हो कि आप कंफर्म करना चाहते हैं। माय क्वेश्चन इज
ओके.
डिफरेंट।
जी सर बताएं.
Don't you have a simple investigation to give you a thought whether it is advanced or not advanced? It is resectable or not resectable? Can't you comment this thing on some very simple investigation?
सर सीटी स्कैन.
It's even simpler than that.
एक्सरे.
Yes, X-ray chest. X-ray
Okay.
chest is going to give you a plethora of investigative findings, which can tell you if it is a locally advanced or early. Not only
Okay.
early locally advanced, it can also tell you whether curative resection is possible or not. It can even tell you whether palliative resection is possible or not.
सही सर.
It can even tell you METs. So carcinoma esophagus is one of those cancers in which X-ray of the chest is very, very important to do.
ओके सर. ठीक है सर.
For example, just to come on this thing, once you do an X-ray chest and you see there is mediastinal widening,
जी सर.
you straight away know it's an advanced carcinoma. It cannot do it. Otherwise, that will not happen.
जी सर.
if you see that it is medicinal enlargement is pretty obvious, and you see there's a splaying of tracheal bifurcation.
Karen. Hmm.
Carina is splayed. Normally it's like
Jesus.
this. It is something like this.
Jesus.
Then it means it is pretty locally advanced, isn't it?
जी सर
If
बिल्कुल.
the chest and you find that one dome of the diaphragm is raised and where it should not be raised, like the left dome of diaphragm is raised, then again,
Hmm.
it means a vagus nerve is involved. It is locally advanced.
जी सर.
Similarly, clinically, if patient has a Horner syndrome, then straight is telling you locally advanced because synthetic chain is involved. Similarly, in X-ray chest, if pleural effusion is present, if MET is visible, it is metastatic.
मिलेगा. जी सर.
Now, if you see this thing that mediastinal widening is there,
Hmm.
or the tumor is near the carina, or these things are present, one thing is sure, that cure is not possible. That's the movie. The
जी सर.
only point now is whether palliative resection is possible or not.
Okay. Okay sir.
Because even if you want to do a palliative resection, then it has to be a safe one.
Safe one.
Now what you're going to do is, आप CT scan और ये बात आपने की, ये बिल्कुल ठीक है, ये आपने कराना ही कराना है क्योंकि patient fit है, क्योंकि this is also going to tell you not only that curative resection is possible or not, or palliative resection is possible or not.
Hmm.
Because if cancer is involving near the atria, atrial wall के साथ लगा हुआ है, ये जो vessel के साथ है और ये चीजें हैं, तो this not only this thing, this will also tell you this thing. If the tumor is pretty near very important structures like atria, like veins, like vessels, what are the chances of doing a safe transthoracic esophagectomy? I'm talking about palliative. You can do or not. And you may say the risk is high, so therefore, even if you want to do palliative esophagectomy, I'm not going to use transthoracic because of local advancement. So many of these informations come when we are talking about this thing. Okay. So you have done these investigations, and patient has carcinoma of the lower esophagus, as you was telling. And now I'm going to put you two different scenarios.
Okay, sir.
One scenario is curative resection is possible. One is that it is an early carcinoma, esophagus.
Okay.
What surgery you will do?
Sir, I will leave this procedure.
I will use procedure.
Ji, sir.
And then the next question is, it is locally advanced carcinoma and it's resectable. What surgery you will do?
Sir, again, IVLUS is most commonly done.
IVLUS is most commonly done.
Sir, I will not do it myself because I'm not experienced at that. So
No, I'm not arguing on this thing. I was question not IVLUS will do. I'm not talking about I'm not talking about
okay, sir.
This brings to a very important discussion. Okay, how to give answers to these questions.
Ji, sir, bilkul.
This thing becomes very important. You see, the problem is this is to achieve the criteria of cure, if the intent is curative, then one have to remove the lymphatic drainage. That is very important. And we also know this thing, en bloc also. They negate hoti hai cheezein, whatever we say.
Ji, sir, bilkul, en bloc.
Or if lymphatic resection is compromised, then it doesn't remain in curative.
Ji, sir. Ji, sir.
This thing should be in the mind. For
Um,
for palliative, lymphatic clearance
is not
is
necessary.
not the point to think about.
Hmm.
Even leaving behind a little tumor is not a point to think about.
Okay.
It means this, it means this thing is that
Sir, so locally advanced में I guess McQueen procedure करेंगे because we need three area clearance: cervical, mediastinal, and abdominal.
अब मैं इसी पॉइंट्स पे आ रहा हूं मैं बट आई एम जस्ट गिविंग यू द ऑडियंस हियरिंग अ बैकग्राउंड व्हाट इज हैपनिंग अराउंड
ठीक है,
so questioning
सही
answer
है सर,
information.
ठीक है सर.
Now the problem is to do an adequate lymphatic clearance of the middle part of the esophagus. That can't be done blindly by transhypal. Very simple. If we want to do clearance of lymphatics in lower one third, that can be done only under vision. That is also true. In simple word, lymphatic drainage, lymphatic को अगर हम निकालना चाहते हैं तो that can only be done under vision, irrespective it is upper, lower, or middle one third. ये एक चीज तुम्हारी क्लियर होगी. It means this thing that if we want to do a curative resection of esophagus, then we will have to open the chest, whether we do is a trans 2-stage or 3-stage, depending upon the site. That is a different issue.
Okay.
But if it is in the lower one third, tumor is there, then we can do adequate clearance of lymphatic lower one third through abdominal approach also.
Okay.
So in this case, there is permissibility of transhiatal esophagectomy in an early carcinoma of the esophagus involving lower one third, because lymphatics आप drain कर देते हैं और जो आपके बाकी जो portion है upper esophagus, upper half of the esophagus rather, उसके lymphatics इतने ज़्यादा important है नहीं, तो आप transhiatal से उसको proceed कर सकते हैं. Rest of the case, it is transthoracic.
Okay.
Now, this is a broad concept of it is. So now my question to you is
जी
that
सर.
lower one third carcinoma, and you want to do is early carcinoma stomach. What do you want to do?
Sir, in early cases, I will do this procedure.
Lower one third.
Lower one third.
This is a perfectly correct answer. You give this, or even if you do give an answer of transhiatal, that is also a correct answer, provided you can do reasoning.
Okay, sir.
तो आपने ठीक जवाब दिया. Provided you don't stick. For example, if you say lower one third, I want to do transhiatal and why? Because under vision you can remove the lymph nodes and this thing, and okay. And he says any other, and you persist no transhiatal. If it's any other, but if you say yes, there is a, we can do transthoracic, we can do. So that's perfectly okay. And if you have given, I will lose, and somebody says, can't you do anything else? Can't you do anything else? And then you come out with transhiatal and give an argumentation, that is also perfectly correct. This is the point just I wanted to bring to you in your.
Okay, sir.
ये चीज आपकी आ गई. अच्छा डॉक्टर साहब, problem is that it's unresectable. What should we do?
So if it is unresectable, then I'll go for palliative procedures.
Which one?
Okay, if the patient is fit for surgery, then I can go even for palliative resection, that is palliative esophagectomy as well. But other things and which are less invasive and
नहीं मुझे बताइए कि why you have suddenly shifted to theory? ये आपने एकदम गियर क्यों बदल लिया है? आप सही गियर पे जा रही थी. What I mean to say, you have told this patient is fit.
okay, sir.
तो फिर ये लखनवी अंदाज आपने क्यों इख्तियार कर लिया घर का? एकदम आपने एक गियर बदला चलते चलते.
Sir, okay, then I can go for palliative esophagectomy.
Yes, जवाब इस तरह देने हैं आपने.
ठीक है, sir.
For palliative esophagectomy. So why not? Is there any other option?
Bypass procedures are also there for in case of surgical esophageal
देखें देखें
gastric bypass.
प्लीज डोंट टॉक टू मी लखनवी अंदाज में.
जी sir.
आप ऐसी बात कहें ना जो कि यहाँ पे अवेलेबल है. आप बाईपास करेंगी क्या इसमें?
Okay, इस केस में मैं सर palliative procedures में सर stenting करूंगी.
Obviously, slow one-third tumor. If you want to palliate dysphagia, there are two things which one can do. One is your palliative esophagectomy, and other is stenting.
जी sir.
ये thoughts आपकी पहले ज़हन में आनी चाहिए.
ठीक है sir.
My question is this: why you are choosing palliative esophagectomy over stenting?
Sir, the patient is fit for surgery, and the palliative esophagectomy will provide her. If it is the survival is more than 6 months, then I should opt for esophagectomy.
सही. आपने बात ये अब आपने जो बात की है, if the patient is fit
and survival is,
then patient can undergo surgery and this thing, and then you want to do, and if you give this argumentation, okay, I want to do is a palliative esophagectomy because the palliation of this thing is of dysphagia is better. Your augmentation is not bad, but how much do you think he's going to survive?
Sir, up to 1 year.
Up to 1 year. So since the survival is only up to 1 year, then don't you think that stenting would be a better option? Because if you do an operation, then out of 1 year of his life, nearly 1.5 months, we have decreased his quality of life because of and the rest time is left is only, let us say, 7-8 months. So to such a big operation with morbidity mortality, don't you think stenting would be an option?
If the surface, sir, it is also about the facilities which we are provided over here as well. Like if the stents are available, then we can go for it.
So the point which I want to bring to this mind is that in a patient is fit for surgery, you have two options. One is palliative esophagectomy and other is stenting.
Okay.
Both answers are more or less acceptable. कौन सी पहले कर रहे हैं in a fit patient. Now, if you're choosing about esophagectomy, then your augmentation should be the palliation is much superior as compared to stent.
Stenting.
Number two, stents are to be replaced. Whereas when you do that thing, so the time of his life which is spent, which is 1 to 1.5 years, whatever it is, will not need second operation. So the argument is going to be on that like that.
Okay, sir.
And if you say stenting, that is also acceptable, provided if somebody says, can something else could be done? Then you say, yes, there is an option of palliative esophagectomy also.
Okay, sir.
Why you are choosing? If you have chosen about esophagectomy, over-stenting, then you're going to give answers which I've done before. But if you have chosen, let us say, stenting, so
जी sir.
then again, you should give the reasoning. It's the prognosis of the half year. Now, if I subject to such a major operation, then after that, life quality of life will decrease for some time. So it's not worth it. If you do argument like that, it is perfectly good and acceptable, and that's a good thought process. The only problem arises is if you fix to one and don't move to other and do not accept the facts,
Okay sir.
then the problem arises.
Hmm.
So if you can debate like that, it's perfectly okay, because whatever answer you will give, few questions will be put to you in which this thought process will come in the mind.
Okay sir.
It is something like that. Okay,
Okay,
now
sir.
the point is that we have only 4 minutes left. So let me do the chat. Let me skip the check. Barium swallow first, then, and we have answered to that. Bone scan. Yes, we have covered that point also. Endoscopic ultrasound available. Yes, if it's an early carcinoma. And bone scan, yes, because there's a carcinoma stomach, involvement of pleura, pericardium is contrarian of curative surgery, sir. The involvement of pleura and pericardium is contraindicated to curative surgery, sir. Well, curative surgery definitely, it means it's a locally advanced disease and curative surgery cannot occur. आप नहीं कर सकेंगे.
जी.
दूसरा ये है कि mind you also कि when you are giving answers, you are not doing a fellowship examination of thoracic surgery.
Okay, sir. जी, sir.
Answers of thoracic surgery will not be same as answers in a general surgery case. They could be different. Number two, this is the reason also that when we discuss these cases with a thoracic surgeon, he might give you answer which may be slightly different from which I am talking to you, because they are trained as thoracic surgeons and they have that mindset of. Other thing is very important, is which we have not covered up, is which you should know in carcinoma esophagus is total parenteral nutrition. That component आपको आना चाहिए, because those questions will come here and there. And obviously, how to increase the calorie requirements and so cell thickening if you cannot swallow. So we're talking in terms of feeding eugeneostomy, feeding gastrostomy. इनकी debate, so ये चीजें भी ज़हन में आनी चाहिए. So you should have knowledge of TPN. You should have the knowledge of enteral feeding, because that component will also be covered in carcinoma esophagus, especially in a case which is very weak, in which is you cannot repair it. You never know. Then a significant proportion of your debate goes to the section of TPN. And we're talking about TPN. We're talking about things which are available in Pakistan, which you can give. Not per se. So उसके बारे में भी आपको थोड़ा बहुत पता होना चाहिए.
सर इसमें और भी चीजें हैं, ये कैनलाइजेशन के प्रोसीजर्स भी बताए हुए हैं कि एंडो लेजर कैनलाइजेशन कर देते हैं आप लोग, एंडोल्यूमिनल एंडोस्कोपिक लेजर, ब्रैकीथेरेपी, ये वाली भी चीजें हैं. सर अगर इस पे भी आप थोड़ा सा हमें बता दें फिर.
So what we do is next time we'll continue from here.
जी सर.
And we will, because हम आज हमने TNM क्लासिफिकेशन भी हमने डिस्कस नहीं की. जी सर, वो भी नहीं डिस्कस इम्पोर्टेंट है, और ये करके साथ हम TPN को कवर कर जाएंगे.
यस सर, प्लीज. थैंक यू सर. थैंक यू.
थर्ड सेशन पे ले जाते हैं. ओके, 10 मिनट. हैव अ गुड डे. एंजॉय योरसेल्फ.
थैंक यू सो मच सर.
बाय बाय.
थैंक यू सर. अल्लाह हाफिज. खुदा हाफिज सर. अल्लाह हाफिज.